Good morning and welcome to day 2 of the National Council on Disability Council meeting. Today's portion is our business meeting portion, in which we have many items to cover today. And at that, I will ask Anna to please read the roll to ensure we have members present.
Sean Kennemer,
Here.
Hosky Benally Jr.,
Here.
Sasha Bittner, Theo Brady,
Here.
no response right now, but,
Theo. I see Theo.
oh, there's Theo. Hi,
Yep,
Theo.
I am here.
Okay. Kim Ridley,
Here. Can you hear me?
there she is.
We see Kim's talking.
Risa Rifkin,
Good morning here. Hopefully you can hear me as well.
yes. Neil Romano,
Here.
I'm here. Joan DeRocher, Nick Sabula, Keith Woods, Amy Nicholas, Jed Solomon, Ann Summers McIntosh is not here. Nettary Lewis, Stacy Brown, and Kimia Kobaki. Okay, that's the roll call, Mr. Chairman.
Thank you. At this point, I will start with the chairman's report. Just a few things I wanted to bring to everyone's attention of what's been going on, both in my local area as well as at the national level. So in December, I had the honor of attending the Autonomous Vehicle Summit in DC, along with Anna, who was the speaker for the National Council on Disabilities, and spoke about our ground transportation report that was released. We released that in August or June?
July.
That we had released in July. We made a lot of good contacts, and I thought it went very well with all of the different autonomous vehicle industry representatives that were there, and pointing out the need for wheelchair accessible vehicles coming down the line to increase independency for people with disabilities. We also made Capitol Hill visits. I introduced my local legislators, or my legislators, Vince Fong, to the council members or the council member staff, as well as David Valadeo. Vince was very influential and very thankful to us for coming to him. He is handling, there are some work that's bipartisan work being handled on Capitol Hill regarding autonomous vehicles. Vince has been assigned to work on the trucking industry area, but he did reach out to the other Congress members. I can't remember their names that he had mentioned, but he did reach out to both of them that were working, one a Republican, one a Democrat, on the person transportation. And so hopefully they'll include us in those conversations going forward, is what we're really trying to get. At the local level, had many meetings with the city of Bakersfield, where I live, and regarding our transportation, bus stops being no parking again. That's an ongoing issue that we discovered that we had thought was taken care of 12 years ago, and it's coming back. So there's a coalition of local providers there that are really hammering the city to make those all no parking. I met at the state level with legislators about HCBS and about the waivers in California for people with disabilities and service providers, specifically with rates that are being proposed and are being unmanaged, are not manageable. That wraps up my report. So at this time, I'm going to ask council members if you give a report or where you've been, what you've been doing. I'll start over here with Sasha.
I do mostly Good morning.
You just read it now.
Now I said good morning, everyone.
Oh, good morning, everyone.
I continue to engage in efforts
I continue to engage in efforts
in the both of determination,
to support self-determination, inclusion,
and better life outcomes
and better life outcomes
for developmentally disabled Californians.
for developmentally disabled Californians.
I was recently reappointed
I was recently reappointed
by Governor Newsom
to
State Council
the State Council
on developmental disabilities.
on developmental disabilities.
I was previously
I was previously
the
chair
emeritus
and then chair emerita
almost 20 years ago.
almost 20 years ago.
I can't believe it. Currently, I'm chairing
Currently, I'm chairing
the
the
self-advocate subcommittee
self-advocate subcommittee
and working to get us the needed training
and working to get us the needed training
to improve our legislative activism.
to improve our legislative activism.
While
While our state budget
will thankfully
will thankfully
be pretty status quo.
will be pretty status quo,
Except for the issues on alluded to.
except for the issues Sean alluded to
For the deal,
for this year.
we are still very worried
We're still very worried
about how the federal Medicaid cuts
about how federal Medicaid cuts
might affect the president services
the services
for Californians
for Californians
with disabilities
with disabilities
in 2027.
in 2027.
So that would probably be big part of my activism this year.
That'll be a big part of my activism this year.
Thank you very much.
Thank you very much.
Thank you, Sasha. I'll turn now to Hosky. Did you have a report?
Sure. There is a group called the Intertribal Disability Advocacy Council, which is composed of several different tribes from New York all the way into California. And what the purpose of that is to begin to look at the needs and issues that face Americans with disabilities, identifying, because there's really not much current information. So about 2 years ago, there was focus groups conducted with people with disabilities. And out of that came a report, and that was reported here to NCD at that time. And so they're moving on now to setting up a symposium. Now this time they're going to work and interview organizations, whether they're local or national, that serve Native Americans with disabilities, and find out where they're located, what services do they provide, what are some of the barriers that they're experiencing as service providers, where does their funding come from, if there was any kind of legislation to be considered, what would their recommendations be? And so that's currently in the works, probably going to happen this coming summer. Then out of that will come another report. from that viewpoint, and then comparing the two that were individually what the focus groups, what we call talking circles, the results of that, and then the results of these organizations. And the other thing, we're way behind in as far as disability rights in Indian country. Example, the Navajo Nation, that's where I'm from. We're still working on issues like polling site accessibilities. We're still working on employment for people with disabilities. The policies, there's currently no policy, so we're pushing that. The president of the Navajo Nation Advisory Council on Disabilities, which is part of the Navajo Nation that was established back in '79. And so with that, in the personnel manual, there's really no language in there about how they will consider people with disabilities for employment within the Navajo Nation government, as well as how they will provide reasonable accommodations. But that legislation is currently on the brink of being passed through the government up to the council, and then to be approved and signed off by the Navajo Nation president. Polling site accessibility is the same thing. We're trying to get something in place before 2026, which is right around the corner. And federal, state, and tribal elections, those three. And so we're trying to put legislation in place where Navajo with disabilities can have more accessible to the polling sites. And we did surveys. We have what they call chapters, 110 of them, which all of them were polling sites. And so we did surveys on 54 of them to find out, and we used the 2016 DOJ polling site accessibility checklist is what we came off of. So that's right around the corner here. Also, after we've been working on these for, I don't know, 5, 6 years, maybe more. The other big issue that we're having is abuse and neglect of Navajo's disability adults from 18 on up. As that target population did not have any kind of protection, and how the process, if there was any kind of abuse, neglect, exploitation, abandonment, where who's going to report, how did they report, that whole process, and how does it eventually, if need be, get to the court system. So those are basically the biggest ones that we're working on, and all the tribes are in that situation. That's the status. A lot of the tribes do not have policies in place within the government and these areas and other areas that are needed. The Navajo Nation passed the Civil Rights for Individual Disabilities Act back in 2018. So we're working on that. I think there's about only 5 or 6 other tribes that have ordinances, and we're talking over 500 tribes. So we're working on those issues through this intertribal group. And the other thing we're doing right now, again, is working on these polling sites to see if we can get something better by 2026 midterm. So basically, I think that's where we're really focusing on right now, and trying to catch up with the rest of the country. And the other thing is IHS in the health services is in treaty with the governments, in treaty with Indian country and different tribes. But IHS is the primary health provider for American Indians for medical services, and also for cognitive disabilities. And we've never been fully funded all these years. And so that causes us to lack specialty services. There's no specialized services at these hospitals, so they send patients who need something either to Albuquerque, Phoenix, Salt Lake, Denver, and they're all about 6 hours away from where we're centered. And so they'll pay you to get there, but you had to find your own way back. Families had to find a way back for their relative, their family member to come back. So those are some of the issues that we still face. And hopefully, I don't know how we can ever get it resolved, but I just like everybody to know that's the situation that we're in. And this is all Native Americans clear across the country. So I just want to report that. Thank you.
Thank you, Husky. Neil.
Thank you, Mr. Chairman. Good morning, everybody. For the last 10 years, I've been involved in a project between the professional baseball athletic trainers, Major League Baseball, and ODEP to discuss the value of people with disabilities in the workplace. And Major League Baseball has put out, a number of public service announcements we've worked on over the last 10 years. Last year, we started a new program to highlight companies in major league cities that have an exceptional work ethic for people with disabilities. And we included in that mental health work. So, and interestingly enough, we started last year with, 15 cities, and we gave out 15 awards, one for each city where we found someone. This year, all 30 cities, major league cities, have applied, and we have gotten hundreds of applications of companies that have asked how we can be better at this, or how did they get this award? And it's become, in baseball, one of the hottest awards you can get, primarily because they understand the value. And Major League Baseball has done such a great job with that, as well as we work very, very carefully on, once again, in conjunction with ODEP. PBATS works with ODEP, and we've worked on mental health and the mental health aspects within baseball. It started first within baseball, because people don't realize that baseball players have mental health problems, because they certainly don't want to show you. But you stand in front of 40,000 people and they boo you or they cheer you, you're having a good day or a bad day mentally sometimes. So we have used that, like we've used the history of ball players with disabilities, to springboard off into some very big mental health programs in the communities that have gone very well. And that project is an ongoing project, as I said, in conjunction with ODEP. We've been partners with ODEP now, I think, for 12 years. It started with our programs for young people. We developed on-field programs for young people with disabilities that required absolutely nothing except for them to show up. And they were wonderful. They had the most fun, and they were great. And, so it's been a very healthy program. And we have every major sports league has tried to copy that, or copied it one way or the other. The other thing is, for the last 6 years, I've been working with a team to find a more effective AI approach to allowing people to register and get Social Security and get their benefits, especially people with disabilities. Something where they would have a longer time, more opportunity. They wouldn't have to sit with someone and answer personal questions, but they could rather have a filter between them with an AI program that helps them get the answers they need in a manner that they can get it. The program has to be sensitive both to the disability. The programs are designed to be sensitive to both hearing and visual issues, mental health issues, all being put together so that, for instance, even for me, doing my renewals and everything is not always easy. So you recognize the problems, but here's a situation where you could sit with a piece of software, and you could ask it the same question 25 times. And it never gets mad at you. It never gets unhappy. It never says, I'm out of time. It never says any of those things. It never says, we've already talked about this. So we're very excited about the fact. And that is a private venture run by a group of people that I'm working with, and actually in 2 different countries. And that's coming to fruition, but we're figuring out ways to translate that over to the disability community to make sure that they're the first in line to be able to use that. And that's been probably the most significant thing in the last year is that, we now have working models up and running of that piece of equipment, and we're working a long time on it. So that's the major things that I'm working on right now, Mr. Chairman. Thank you.
Thank you, Dale. Theo,
Yes, sir. Can you hear me okay?
hold on, or let's make sure that we can hear you. Try again, Theo.
Can you hear me? Testing 1, 2, 3, 4.
Hold on. Hold on real quick. We're trying to get the audio in here.
Testing 1, 2, 3, 4. Can you hear me now?
Yeah.
Testing. Can you hear me? Testing 1, 2, 3, 4. Testing. Testing 1, 2, 3,
We know it
4.
works because it worked yesterday.
Right.
That was just. Good thing is we do have time, so just bear with us.
Testing 1, 2, 3, 4. Testing. Testing. Testing 1, 2, 3, 4. Testing 1, 2, 3, 4.
Theo, can you say something?
Testing 1, 2, 3, 4.
We got you.
All right,
You're
all
on,
right,
my friend.
all right. Thank you. Let's blame all of this on Neil. Um, thank you all for allowing me to talk a few minutes here about some of the things that is affecting us. Some of you all may or may not know that I am the executive director of the National Council on Independent Living, and much of our membership is made up of Centers for Independent Living and statewide independent living councils. So that's where I really speak about in regard to the things that I'm hearing from them. Many of our members right now, member centers, are struggling, trying to figure out how to maintain their mission, right? How to do their work with this current administration. By mandate, our member centers are required to look at our data every year and see who we are not serving and who are the underrepresented. And then based on those numbers, then we try to do some innovative things, creative things to ensure that we reach out to those individuals and develop ways to serve those underserved population better. But typically those individuals are from the BIPOC community, Asian American, Native American, LGBTQ plus community, as well as immigrants and other marginalized groups. So you can see that where I'm going with this, right? They can't be innovative anymore because they are stagnated because they believe and rightful so, that monies will be pulled back. Some centers already have lost, $10 million in regard to just services that they provide to immigrants, right? And so we are sort of stagnated in a way, waiting to see what happened, right? And so because we are concerned about whether, our grants will continue or our grants will be eliminated. And I know NCD can't do anything about this, and I recognize that, but I want you all to know where we are at and where people with disabilities are at right now. They're in a situation where they are maintaining, not being able to be innovative, not being able to plan strategically to serve those individuals who are not being served and underrepresented. So I just want to, bring that forth and let everybody know that that's where we're at, and that's what I'm hearing. So thank you very much.
Thank you, Theo. Risa, are you on?
I am here. Can you hear me?
We have you. Yes.
Perfect. I apologize for not being on video, but it is 6 a.m. here, and you don't want to see me yet. But I appreciate being here and participating. I was out of commission for a couple of months towards the end of the year, so I really am just getting back and don't have too much to report, and really appreciate all that has been shared already and what people are working on. I will elevate, that the panel yesterday about nursing homes. I have heard conversations that relate directly to just how much institutionalization continues to happen for our community and move of institutionalization in different ways for other parts of our community as well. And that, the disability community is very concerned about this continued trend. I'll leave it there and thank you again.
Thank you, Risa. Kim,
Hi, can you guys hear me?
we have you. Yes.
Great. Good morning, everyone. Thank you for the opportunity for me to talk. I just want to level set as Theo did. I'm coming at this from the perspective of Chief Disability Officer for the state of New York. So fortunate to have the position that I do, in which I have a pretty good lens as to what's happening across the disability community in New York. And I would like to echo what almost everyone has said about still being concerned about potential Medicaid cuts. I think that we live in that fear space regularly. And like Theo said, I'm not sure that there's anything NCD can do about it, but I think all of us recognizing that it is a bad space for all of us to be in still is important to do. Aside from that, we have been incredibly busy implementing two executive orders in regards to employment. One commits the state to being a model employer, and the other commits the state to being an employment first state. We now have a team of what will be 5 people working on that. And we work very closely with our friends at SEED and ODEP to help us guide us and also connect us with other states that are working strongly on employment for people with disabilities. In fact, we host, I may have mentioned this before, we host a 2-day event every October. We call it DREAM, for Disability Rights and Employment Awareness Month. When we started doing this as part of our NDM efforts, I wanted to make sure that eventually we could start talking about disability rights, like housing, transportation, home care, emergency preparedness, all of the other things that allow us to work in the community, similarly to our non-disabled peers. And this 2-day event has really evolved, and what we are hoping to turn it into is a national conference on employment best practices. So I'd love for any of my NCD colleagues who have an interest in participating in this event going into 2026. We'd love to have you, love to talk to you about what is going on in each of your states. Additionally, we've created a tech consortium charged with creating and vetting new technology aimed at making people with disabilities more independent. It's about a 2.5 or a 3-year grant that collaborates with our State University of New York at Albany College. And we have a proposal in the governor's state of the state and budget that will make that last longer through our economic development agency. We are also getting very close to getting our renewed deaf, blind, and hard of hearing interagency coordinating council up and running. It's been 2 years since we opened a deaf, blind, and hard of hearing office within the Chief Disability Office. And we are very close to this interagency council made up of a number of deaf, blind, and hard of hearing individuals up and running again in a way that we think is going to be very functional and provide great advisement to us. And I will close it out by saying we are proud to be working with our housing agency to improve the amount of accessible and affordable housing for people with disabilities, and are hoping to do even more in the next coming years. Well, I think I'll just stop there for now, but thank you for the opportunity.
Thank you. Thank you to all the council members for your reports. Much appreciated to hear about the work that we're doing at the federal and state level. So with that, we're going to move on to our executive committee reports, and I will turn it for the governance reports to Sasha.
For the record,
For the record,
the council voted
the council voted
to approve
to approve
the 3.85 million
the $3.85 million
dollar
plan budget
for fiscal year 26
for fiscal year 26
in September 2025.
in September 2025.
This statement
Memorializes it for the record.
And that is my report.
And that's my report.
Thank you, Sasha. At this time, I'm going to invite Keith. Would you come up and give our financial report? I just want to, while Keith's walking up, just want to point out that you all know about the government shutdown that occurred at the end of last year. And I just want to thank Keith for all the work that you did trying to get us through that, and all the budgeting work and the issues that we've had to face. So with that, turn it over to Keith.
Is it on now? Okay. Thank you, Mr. Chairman, and good morning. For starters, I'm gonna be rounding the numbers up to 100,000 for the benefit of the transcriber, because I know I talk a little fast. Our CR budget is $1.3 million. To date, through December 31st, we spent $600,000, which is 45%. So to date, we have $150,000 in savings. We can use that $150,000 for either projects or however leadership sees fit. The $150,000 savings came from mostly due to the government shutdown, because we had a delayed on the NTE hiring. All of our annualized contracts was reduced by 13%. So in all that, it saved us $150,000. Finally, we was going through the 2024 and 25 biannual audit for the last probably 6.5 months. It came to a close. It's coming to a close right now. And we get an unqualified opinion. What that means is we passed the audit. This concludes my report.
All right.
Any questions? I'm sorry.
Any questions from the council members regarding this? So I'm sorry. So you mentioned the CR. I do have one. So
Yeah,
continuing resolution, and that ends when?
January 31st.
January 31st. And right
Yeah.
now we have no knowledge of anything passing, or if we're
Not
going
to my
back into a
knowledge.
shutdown.
Not to my knowledge. I haven't heard anything.
Okay. So the 150,000 is money that's left over just for the CR, correct?
Yet, yeah, definitely.
Okay.
And I will be giving updates every quarter going forward on what savings we have, so
Okay.
we can manage accordingly.
Any questions? Neil?
I'm a little bit confused. Forgive me, I'm not good with numbers and you know that.
Okay.
The 150, so how much is left in the budget between now and the end of the CR? Is that
150,000.
150,000?
Yep.
And how much is totally?
That's not committed. That's not committed.
That's not committed?
Yep.
Okay. And how much is total and committed?
Like 1,135,000.
Just to the end of January 31st?
January 31st, yes.
Okay, so we're a little bit ahead.
Yep.
Because of that gap.
We're in good shape. Yep.
Yeah, because of that gap. Okay, thank
Yep.
you very much. I appreciate that.
Thank you. Any other questions? Hannah, did you have a question?
I don't.
Oh, okay. All right. At that, do I have a motion to approve the financial report? Sasha moves. Do I have a second?
Second.
Hosky seconds. Then all in favor, say aye. Any opposed? Hearing none, then the motion carries. The financial reports. Thank you, Keith. So we'll now move to the legislative and media updates. So if can have Kimmy and Nick also come down and join us and give their reports. It's right up front. All right. Oh, here, John. There.
Thank you. Good morning, Mr. Chairman. So the Legislative Affairs team, we have been monitoring key dates remaining in the 119th Congress. The first one I wanted to clarify that on January 30th, if Congress doesn't pass our appropriation bills, funding will lapse for the government. I will say last night, the House did pass the final of the 12 spending bills, so they will go to the Senate next week. And hopefully by then, the Senate can pass the bills and we will all be funded. One of the things I did learn is that the labor, HHS, education, and related agencies, which governs our agency, NCD, is going to be reconciled last of all the bills, and that's just because of all of the recent healthcare policies that the president has been having. So like the recent vaccination schedules, the food pyramid, the new negotiations with the most favored nation. So with the drugs, with the pharmaceutical companies. So it's going to take us a little bit longer. But I will say that I was looking at the appropriations, and both the House and the Senate have NCD's budget for fiscal year 2026 as being $3,850,000. So there's no change there. The next big date that we were looking at is February 4th, which is the Presidential State of the Union. So we will learn the president's key initiatives. Let's see. And then late August, September, Congress is expected to pass the Surface Transportation Reauthorization Act, which I'll talk about later in our meetings in December, which you mentioned, Mr. Chairman, with members of the Transportation and Infrastructure Committee. And then in November, we have elections. So that kind of tells you we have how much time we have to pass any bills. But I will say, looking back at last year, it was very unique. Congress passed only 68 bills, which is extremely low. And that was probably due to the very narrow margin between the two parties. And right now we have 4 vacancies starting this year. So it's going to be very interesting to see how many bills will pass this year. So people are saying that's going to be very low again. But the key bills that will pass are that are intended to pass are appropriations and the Surface Transportation Reauthorization Act and healthcare issues. So back in December, as you mentioned, Mr. Chairman, we had a marathon of meetings with members of with key staffers on members of the Transportation and Infrastructure Committee. That is the committee that governs the Surface Transportation Reauthorization Act. So we were talking to them about certain recommendations from our recent ground transportation report, and we have some interest there. Then a couple weeks into, I would say mid-December, Ann and I met with Congressman Van Drew, who is also, or his staffer. We did a follow-up meeting with him to gauge his interest in doing some appropriations language in the fiscal year 2027 appropriation package. And so for those people who aren't familiar with appropriations, what Congress can do is add directives so appropriations is the money for a bill. But Congress can attach directives within the money. And so we have some ideas internally. We've been thinking of some ideas from the ground transportation report and along with our other reports as well, too. So that concludes my report for the Legislative Affairs team, Mr. Chairman, and I'm open for any questions that you guys may have.
Any questions? None? Thank you, Kimmy, for your report. Nick, do you want to give us a media update report?
Absolutely. Good morning, Mr. Chairman, members of the council. I'm Nick Sabula, the Public Affairs Specialist for our team. And one of the things interesting for me coming down this week, next week's going to be 10 years since my retirement from the U.S. Air Force. And it kind of felt like a deployment coming down here, honestly. Any of you who've been in the room have seen the number of Pelican cases and all of that stuff. And thankfully, NCD's made an investment in our public affairs program and tried to facilitate just a better experience for the public at large. Some of the things that we've done is invest in cameras, other things over the last couple years, and we are always looking for feedback on the ways to improve how we're putting out our programs, our content, all of that. So some of the things that I wanted to just shortly go over today, just looking at in media in general, NCD being one of these smaller agencies in the federal government, we have a very specific role, and often media who contact us, they're looking for maybe a different type of picture, maybe an advocacy view, something like that. And so one of the things that we look diligently towards is how's the content of what we do as a federal agency and our important role in government, how does that translate to the story that the reporter is looking to do? And so a lot of times we are my role is ensuring that they get the best content possible. So often we are referring them out to other agencies and making sure that they have the information they need from us because we put out over 400 reports as a council. And so a lot of that will come from media coverage, not so much more academic coverage, or if in articles we'll get a second maybe attribution to us on something that came out on our reports. So looking forward for any media queries that come in, obviously we got one last night from one of the local channels that wanted to talk to us about some things. So looking through on our social media programs that we have, through December 25, over the last year, our social media platforms, Facebook, Instagram, LinkedIn, X, and YouTube, have gotten about 104,000 followers. It's about a 7% increase over the year. So we continue to put out content, and feel free to join in that conversation by following some of our pages. Wanted to talk quickly about our Speakers Bureau program. This is one of the things that we've had for a long time, and we have not it's not been very active, and that's one of the things over the next year or two. We're going to look at what is our footprint and how we can better support the things that come in. We get about a dozen requests for speakers a year, and we have to look at location, funding costs, all of that, and then obviously most people don't recognize that the council is a part-time council, so you're not full-time full-time employees as far as the government's concerned. You all have day jobs. So us trying to balance that, we work through, look at that. We've got one we're working right now. And so, but we will continue to support that. And anybody who would like to do a Speakers Bureau request can go to our website at ncd.gov. That's GOV. And speaking of the website, we've had several messages from academic researchers. One of the things we talk about, the shutdown that impacts people, a lot of researchers go to our website looking for content, and the shutdown, unfortunately, when the government shuts down, all of our websites and all that go offline also. So for any of folks who are actually doing that, they just need to be cognizant of that fact. So we do get a lot of website traffic, though, and we get a lot of people who are reading reports. In 2025, we had almost 9,500 reports that were downloaded off of our website. Again, we have almost 400 reports online to go through. So there's a lot of content there. In fact, being one of the smallest footprints in government as far as a federal agency, we actually have according to cloud.gov, we have one of the largest websites out there. So it's just because of the number of letters that we've written, and we go back all the way to the beginning as far as things that we posted. So our website, again, not designed to be flashy, but it's really information based. Social media is more where we post pictures and all of those things. So looking in 2025, about 130,000 visitors to the website, about 11,000 in the last 30 days. How people reach it, most people just type in ncd.gov, some organic searches on your search engines, or referral from somebody else. Only about 6,000 organically from social media. So when we look at social media as like the big way that people find us, there's a lot of different avenues. And in looking at that, when we look at accessibility, because that was one of the things we did when we created the website, about 76% are desktop users and about 22% are mobile users. People like Sean, 0.9% people use tablets to access our website. So, and one of the interesting things about how they reach it, we talk about AI and all of that, and how it's shaping how people get information. About 3.1% of people accessing our website are using ChatGPT. So, social media, it's in the ones and twos as far as people, how they look at it. Most of them are direct or by Google. So we use search.gov as our main way for people to search through our website. And we had in the last year about 2,800 queries on the website for different topics. Assisted suicide was first, IDEA, Ability One, ADA, guardianship, our progress report, rocking the cradle, disasters, and publications, which is actually where all of our reports used to be housed on the old website before we transitioned to cloud.gov. So, and let's see here. Okay, that's my report, pending any questions.
Any questions? No? Seeing none, thank you. Thank you once again, Nick. Excellent. At this time that we're going to go on a break for about 20 minutes. We were about 10 minutes ahead of schedule. So we will be back at 10:25. Thanks. Nick, are we ready to go? Nick, are we ready to go? Awesome. We're good. Okay, great. Welcome back. As we continue our meeting today, we have right now we're going to review the description of disability competency curriculum and medical education and training project and an update on requests for information. And I'm going to turn it over to Amjad.
Good morning. As we all know, it is with good reason that this council voted to approve this project to develop a policy brief on the subject of disability clinical care and competency training. The lack of comprehensive disability clinical care education and disability competency training among medical, nursing, and other healthcare professionals can perpetuate discrimination in healthcare against people with disabilities and significantly contributes to the disparate health outcomes of people with disabilities. Federally financed medical, nursing, healthcare professional, and allied health professional schools, as well as postgraduate residency and fellowship programs, do not typically incorporate disability clinical care into curricula or training. Consequently, physicians often lack the knowledge, experience, and skills to distinguish clinical concerns arising from disability from those related to other health conditions. One's apparent disability, even when unrelated to the reason for one's healthcare visit, can result in diagnostic overshadowing the clinical concern and can have negative impact during the healthcare visit. This lack of familiarity and understanding of disability is detrimental to quality of care, contributing to delays in diagnosis and treatment, unsafe care, and inequities in care. Accordingly, the request for information NCD issued last month asked the following questions. 1. What are the challenges and obstacles for schools within the U.S. to adopt and incorporate an appropriate disability clinical care curriculum over the course of their students' training? 2. What is the connection between clinical confidence and changes in behavior and attitudes among healthcare providers? 3. What are the transferable skills that clinicians can learn from disability competency training to apply to all other patient populations? For instance, people who are elderly, those with complex and chronic coexisting conditions, etc. 4. What are the existing curriculum resources that can be adopted and incorporated into current provider training? And 5, what are examples of existing curriculum or standards of learning inclusive of disability clinical care and competency training that could be consulted for development of new required standards of learning across medical schools and or adopted wholesale as part of a program's education of medical professionals? I'm happy to report that NCD received a strong response rate to this RFI, having received 64 responses, as well as input from NCD's established dream team of advisors on issues pertaining to health disparities. The natures of, and I'll just say, we kept receiving responses after the closeout date, but at some point you got to cut it off. But the response rate really was fantastic. The nature of those responses was mostly of policy recommendations, with input coming in from various NGOs, academics, healthcare facilities, doctors, and nurses. One response, however, was of a more personal nature. It was a response that again highlights the urgency of this issue. The submission spoke of a family member with an intellectual and developmental disability, and they submitted his picture. They spoke of how that family member was admitted to a clinic and was tased 3 times while admitted. They also spoke of how the family was not made aware that their family member had been tased or that the admitted individual was given, they believe, the wrong medicine. His picture was submitted to NCD because that admitted family member passed away while admitted at the clinic. It is the family's belief that it was the improper prescription that killed him. But it is also their belief that it was the lack of training and understanding of treating people with disabilities that was the larger concern. The input NCD received widely make the same basic points. They include the following. 1, providers are simply hesitant to or unable to provide proper care because, simply put, they do not have the proper training to do so. 2, the skills gained through disability clinical care and competency training, including communication that is both effective and respectful, interprofessional collaboration, and assessment skills, are transferable to other patient populations. 3, training should involve working directly with patients with disabilities, including intellectual and developmental disabilities. That proximity is key to helping students understand and reflect on their biases regarding people with disabilities and learn how to overcome them. 4, medical schools hiring educators able to provide this training is essential. And while medical training programs value their autonomy, it is important that these programs are aware of and can adopt sensible model curricula already available, including well-regarded core curricula. 5, training programs all too often base their frameworks on the medical model of disability, as opposed to the demographic rights model of disability. 6, in medical training, every program is competing for resources and space. And absent a national standard, disability clinical care and competency training is neglected. Based on the input received, as well as NCD's own attention to this vital issue over the past several years, the following basic recommendations, which will no doubt be refined and added to through continued study over the course of the development of this policy brief, should be considered by this council. The first recommendation that I put forth to you all today. Medical schools should be advised to adopt disability clinical care and competency curricula. The core competencies on disability for healthcare education, developed by the Alliance for Disability and Healthcare Education, defines cross-disability and interprofessional standards applicable to all healthcare disciplines. The Accreditation Council for Graduate Medical Education has itself highlighted these core competencies, as has NCD incorporated these core competencies in its previously published recommended framework. NCD should again recommend said previously defined core competencies in this brief, as they are considerate of the rights of the patient, but also note and incorporate as necessary other model curricula developed by respected organizations over the course of this project. Organizations, including but not limited to the World Health Organization, who we've been in touch with. It just so happens that they are working currently on producing their model curricula, and it's due out in May, and Special Olympics, etc. Necessary education on the diagnostic overshadowing should also be emphasized. This would give the provider in training the skills and confidence they need, while also working off a core set of competencies that respect the individual and his or her rights. Second recommendation we put forth: a vibrant competency-based curriculum to teach nursing and other healthcare professional students the basic clinical skills that is also needed to effectively treat patients across all categories of disabilities, and must include respectful interactions, including etiquette and awareness, problem solving, i.e. a scheme-based approach to history taking and physical examinations, among other needs. Furthermore, real-time interaction with patients with various disabilities, self-advocates, families, direct support professionals, and caregivers is necessary. This too has been previously identified by NCD and should be incorporated into this brief, in this more in-depth brief. While NCD's previous framework to end health disparities of people with disabilities certainly addressed this issue, this brief is obviously intended to be much more in-depth. It is crucial that all allied health professional schools be included so that the patient receives proper care at every stage of their health care. Third recommendation: NCD should recommend that the model core competencies it has identified is adopted as guidance where not yet present, including in coordination with federal entities and entities empowered by the federal government and influential NGOs. Further, while there has been pushback previously, NCD should again recommend that the competencies it outlines be adopted as standards by accrediting bodies. In consideration of the pushback accrediting bodies have given in the past, based on institutions' emphasis placed on autonomy, the good should not be neglected for the perfect. Thus, increased guidance in this space should again be pursued. But the necessity of national standards being adopted should not be ignored. As was noted in the input NCD received, without a national standard, there is considerably less incentive for training institutions to act. And we've seen that. 4, NCD should recommend that entities responsible for state licensing examinations include questions related to disability clinical care and competency training, thereby encouraging medical education programs that teach for the test. Medical education curricula and licensing questions have a dependent relationship. 5, postgraduate training in this space should also be recommended through inclusive health education for postgraduate primary care residency programs. Here too, relevant guidance should be pursued, while at the same time striving for national standards. No doubt NCD has worked on the disparities of people with disability in the health space for several years. And while we've had considerable success in with respect to oral health, getting the same type of achievements done on the medical side of this question has proven to be more elusive. We've certainly collaborated with the NGOs and the accrediting bodies that have a say in this, and there's been a push for medical schools and residency programs to do this of their own volition, which is wonderful. But still, there's a lot more work to be done. And it's obvious that is why this council approved a more in-depth project in this space. And with that, I'm happy to answer questions as the council considers these.
Questions? Neil.
Mr. Chairman, thank you. Solomon, thank you very much for your report. I'm going to ask you the obvious questions. And I'm not going to use the names of the organizations because I don't want to embarrass anybody. But has the AMA or the ADA said anything about this?
So the ADA, back when we were working on the oral health side of this, we did accomplish a very good thing with them, and kudos to them for doing it. Previously, their professional code did not say anything about turning away a patient based on their disability. It had said they cannot turn away a patient based on their race and other such considerations, but it actually said nothing about disability. And working with NCD, to their credit, they did change their professional code to say that a patient cannot be turned away based on their disability. And if the provider is unable to treat that patient, they have to refer the patient to a provider that can provide treatment. It used to be that the patient would be turned to the street. So that was a significant development, and we've seen progress made on the street because of that.
Excuse me, but I'm asking you about this RFI. Have we heard from?
No, we have not heard from the ADA.
We haven't heard from either. Have we attempted to speak to them directly and send it to them directly? I mean, this is not you. I'm just saying, have we worked with any of our actors that do work with us to try and bridge that gap?
We did not call the AMA specifically, but we did put the RFI out through our typical channels. And I think one of the reasons we got a significant response rate is because it went through those networks like a dry leaf on fire. We've heard back from Special Olympics. We've heard back from several doctors and nurses allied through NGO groups, but we did not receive a specific response from the AMA. But based on past experience, the AMA is not opposed to this type of curricula being established, but they also don't have a lot of direct say in how medical schools adopt their curricula. We've also worked with ACGME in this space, and it was through NCD's collaboration that the ACGME, which is the Accreditation Council of Graduate Medical Education, basically they're in charge of residency programs, and the AMA, there was a joint conference, I believe it was last year, if not the year before, where they addressed this issue. They specifically put together a conference for this issue at NCD's request, and they had a wonderful turnout. And it's because of efforts like that it is starting to become more widely accepted that something should be done, but it's the lack of a national standard that precludes every medical school having to do this.
I guess the point I'm getting to, and I think you understand too, when we've had groups like the AADMD that have been very active with us, and some of their members, Dr. Rader, right at the point. I mean, these are groups that have worked very, very hard to get the AMA and the American Dental Association to the table to talk about issues regarding disabilities, if it wouldn't help. Because as much as they don't have necessarily a step in accreditation, and they don't have a step within curriculum writing, they certainly are the 600-pound gorilla in everything that has anything to do with medicine in America. So to at least understand where they stand, or at least to even get a degree of support. Obviously, I know they have been trying through the AADMD. I chaired two meetings between between the AMA, ADA, and AADMD, and there was a desire to make some kind of progress, even on the part of the AMA. I think it'd probably be incumbent upon us to just give it a little bit of a push. Just even if we do it through, a Dr. Rader, or do it through that group, to just say, hey, we haven't heard from them. What is their opinion on this?
Right. Well, I think to clarify, I think it's certainly, sir, we should circle back to them to see where they are currently. We had been in talks with them in recent previous years, where the position of the ACGME, for example, was that they want this to be done, but they don't believe that a national standard should be applied, because they support medical schools and residency programs having autonomy. That was the last thing we heard from them, but we certainly should circle back and see take their temperature currently.
Yeah, I'm using you as the example here because you're the guy. I mean, you push so hard. I mean, you talk about, anyone in this room doesn't know, he pushed so hard against the American Dental Association and got historic change with the work you did. I just think doing it with the AMA, is the kind of thing that's probably going to be needed here. And as I said, we just need them. We need them in the boat.
Right.
They don't have to be pulling an oar, but we need them in the boat.
Right.
Okay. Thank you very much. And thank you for your past work. It's
My pleasure.
It's always been a pleasure. Thank you.
Thank you, Neil. Sasha, did you have a question?
Yeah, but first of all, I have a couple of comments. And then I have a question. In 2013, I was diagnosed with lymphoma. And the process of diagnosis was horrendous. I kept trying to get x-rays of my chest because I was coughing, and they didn't even want to give me x-rays. They said, well, it's probably related to your disability, and I'm like, can you at least check? It turned out I had lymphoma, and I had to spend 6 months in the hospital. And then there was another ordeal, but then I thought it might get better. But a few months ago, I had to have a colonoscopy, and they required me to take the nasty formula that you have to take. And like I tried, there's another way to do it, but then I'm like, no, you have to take that. And I ended up having to have an NC tube because I couldn't take it only. And I tried to tell them, I told them the kids going to work. And I had to actually get colonoscopy twice in a week because the first time I had thrown up. And my point is that I think because of the culture of medical schools, that they don't really want to listen to the patient. And I think, from my understanding, every specialty is hyper-focused on whatever the specialty is, so whether it's gastro or hematology or whatever, and they don't really look at your human being, and they don't really consider that sometimes maybe people have two different things going on emotionally. And my my roundabout question. And do you know what role communication and listening, like that's going to be a big theme within our board wide communication and listening to the patient.
Yes, absolutely. And unfortunately, that your example is a classic example of diagnostic overshadowing. And listening to the patient communication is a big part of the training that's necessary. And that is certainly a core aspect of this project and our previous work as well.
And if you ever want me to give testimony wherever, I'd be willing to, because I've been in the hospital for 6 months. I developed a deep respect for the medical professor's nurse, and yet when he found that he also needed training, like I understand with nurses and doctors, they have so much to do and not enough time. But we really needed something required for disability competency, or they just won't have the time or energy to do it. Thank you.
Thank you, Sasha. I have a question. So you mentioned that the powers are is it the American Medical Association, the AMA, that they don't really like to have or set standards nationally. So are there,
Well,
whoever that is are there not national standards to become a doctor already? Or so medical schools already have that, right?
Right.
Because I just can't open a medical school and say you're a doctor for taking one class, right?
Right. So it's not the AMA, it's the Liaison Committee on Medical Education that sets the national standards for medical schools. And they are sort of supported by the AMA and on the AAMC, I believe. And they have standards. And the history of this is that NCD approached them and said, you have standards, this needs to be a standard. And they said no. And we gave them examples where, other similar standards exist. And they said their response was to say, okay, you're right, other similar standards exist, so we're going to get rid of those. And we just believe in medical schools having autonomy in this space, and they just did not want to do this.
So this would be something that Congress should take up and say, no, enough. This will be a standard, correct?
It gets a little bit tricky because the LCME is given their authority from the Department of Education, and the Department of Education is a little bit in flux right now. But certainly, if there was legislation passed by Congress, it would overrule. That's a challenging thing to accomplish from our experience in the past. But yes, that would be one approach.
Great. Yeah. Any other comments or questions from the? Sasha, I'll get right back. Neil?
I just have a question, Solomon. Yesterday we heard a lot about transportation, and whatever we hear about, we hear the words fear come up. You know, how people, how things, I think one of the things we need to look at, even if we look at it peripherally, is what are the fears and concerns of doctors that would want them not to do this? You know, what has been, what have been the fears? I know we all sit around as people who know the field and everything, but I've also met people who are some of the finest people from the finest doctors, and they say, I'm just afraid to work with that population.
Right.
I don't know anything about them. And understanding that, letting them understand, we understand that doesn't make you a bad person. It makes you a person who is just as concerned about working with another population. They just simply don't understand them. I've never been trained. Say, well, this is that opportunity. I just think we need to take a little bit of time. When we worked in the field of employment, even here at NCD, one of the things we did was we tried to work to understand the fears of the employer for hiring people with disabilities. This is the same kind of thing. I guess in the final analysis is, as much as I'm kind of a straightforward, throw the spear right down the middle of the hall guy, I also recognize the fact that we do have to recognize, in order to get complete buy-in, we do have to recognize what the issues are and say, and this is why this is necessary for many, many people. I have a young person, is a friend of mine who just went through medical training, not 1 second about disabilities that you hear.
Right.
And she was terribly disappointed. She's just she said, I couldn't believe it, Mr. Romano, not a word. She said, and I'm afraid to find out on my own. I don't know where to go. I don't know, which disability, which subject. So it's just a comment, and I know you're probably considering this, but it's just a comment to make sure that it's part of it. But
right.
I'm now part of your committee, so we have no choice.
And we're happy, very pleased about that, right?
Thank you very much. Thank you, Mr. Chairman. Thank you, Solomon.
Sasha?
First of all, I would like to be a part of the committee if at all possible.
Can stop you right there. So can you tell me which council members are part of that committee?
Currently, we have Hosky, we have Theo, we have Risa, and Neil just joined. So that's Neil's the fourth.
Please add Sasha, so that could be the majority of the council.
Right.
I think the more the barrier on this one. So Sasha, you're part of that committee.
Right. And perhaps this is something that could happen off mic, but if we had 5, I don't know would that be quorum?
For a report, I don't believe that would, there's no votes being taken place on that, so.
More the merrier.
Ask Joan.
Right.
Joan?
Yeah. Part of very simple over forum.
We try with, the subcommittee setup that we don't go over quorum, so somebody would likely have to go off of the subcommittee. If we're adding in 5, 4 is okay.
If there's no votes taking place other than on this one report, because it is a committee, committees typically can be for as many people on a committee as you want, because it's not an active process. So by statute,
there are votes that take place within that subcommittee.
within the committee to report to the full council.
So what it is that in the bylaws, if a quorum deliberates on an issue, which the subcommittee does while they're developing the report, it's supposed to take place in the public once you have quorum. And then 5 would be quorum in the current state of the council. So you can't go higher than 4 on a subcommittee.
So you're saying unless it's going to be open to the public?
Right. Otherwise, it has to be open to the public. The deliberations. Yes.
Yeah, we'll discuss that further soon. We'll discuss that further. So any other questions right now, Sasha?
I would say that there was an inherent ableism.
There's a, I didn't catch it.
An inherent ableism in medical schools.
There's a, what, an enablism? An error? I'm sorry.
Inherent.
Ableism.
There's inherent ableism in medical schools
That is baked in.
that is
Baked in.
baked in.
Because of the culture.
Some because of the culture.
And also because of the nature of.
And also because of the nature
of what they do.
of what they do.
Yeah. And there was any way for me to help, let me know.
If there's any way for me to help them, though.
And then help this committee, let me know.
To help this committee, let me know.
Even if it's the public speaking on this matter.
Even, I'm sorry, say it again.
Even if it is public speaking.
Even if it's public speaking on this matter.
We'll figure out the committee assignments soon. Hopefully by the end of next week, we'll have that figured out so that we'll proceed forward. Real quick, this, Mr. Solomon, the report is a brief or a full report?
Based on the project put forth by Mr. Romano, it's a policy brief similar to the dental brief we put out several years back. Just would follow on the medical side.
So there's no difference in terms the report and brief.
A brief typically is shorter than a full blown report.
Okay.
Yeah.
And when what is the timeline for that completion?
The timeline would be for this to be released in the summer, typically is what we aim for. The World Health Organization is going to put out its model curricula in May, and we're certainly going to want to take a look at that before we publish. And typically these briefs come out in the summer, and then inevitably they always get released in the fall. No matter how many times NCD tries, that's the timeline that gets.
I'm just confirming this is not 2 years.
No.
We're pushing on this.
It's for this fiscal year. Yes.
Perfect.
Yes.
Okay, that's what I have. Any other questions?
Well, toward that end, Mr. Chairman, you raised something that I think Anna's probably going to go, oh, no, not that again. I think that when this report comes out or before it comes out, maybe to put together a very brief, a couple of page piece that says signals what we're doing, signals legislative opportunity, and maybe that can even proceed, or have the report come out. I always talk about these very short reports that we send to Congress and the White House, so that we have a stake in the ground at the right time, because we want to be in the ground. Obviously, we want this to be at least be noticed during the World Health Organization, and we want to. I would hate, after working on this for you guys for 2.5 years, us be Me Tooism. Not that there's anything, but we've led. So if you don't mind, let's try and lead.
Oh, absolutely.
Yeah.
We don't.
If I may, sir.
Yes.
Yeah, Anna's.
One of the things that, this is such an important topic, and we see people with disabilities facing this every single day. And that's why you're doing it, obviously. But we continue to get stories from people all the time. Just a misunderstanding of what's going on when they go to a doctor. Doctors just looking at them and saying, go somewhere else and get treated because I just don't get you. Or finding ways to say that without explicitly saying it. But I will say that on your idea, we did something that we had not done previously to help people understand our work better. and to get the word out better. The legislative team put together a series of mini briefings, and they put them online, and they put them forth, and they got a lot of people to come and sit in on those briefings. They were very short, or like what, Kimmy, we were maybe 30 minutes, no more than that, on the different areas, and it was really popular. And those things stay online so that people can come and reference them later. And I think that that might be a powerful tool on this one too.
And if I may,
I'm sorry.
no, go ahead, sir.
I mean, I agree. Something along those lines. I mean, it's the same thing we probably did 10 years ago with regard to employment. When Anne put together a series of things that we spoke at on the Hill, just as a brief in advance to say, this is what we're doing. And it got a great deal of high marks. So the same kind of thing again. And the only reason I think of doing something early is that with the entire medical committee that was formed by our late chairman, Mr. Gallegos, we started putting out little pieces of that in advance. That was also very helpful in drawing more people to the issue. So a combination, however you want to do it, I just think that that's worth it. This subject's worth it.
I think so too. And I think that you can be working with Anne and the legislative team, your subcommittee. That would be perfect. You feed her the information, and she can get those things put together for you in the timeline that you want.
Perfect.
Right.
Any other questions from the council? Hearing and seeing none, then we're going to thank you for your work and continue to hear from you in the future about this going forward. Oh, Kim.
Hi, Sean. Thank you so much. I just really quickly wanted to say, Jed, thank you so much for this presentation. This issue is so critical. Thinking about all the things that we've discussed over the last 24 hours, many of them critical to the independence and inclusion of people with disabilities across the country. If we don't have our health, all of the other stuff is really irrelevant. And when many of us go to a doctor and either the doctor is not very participatory in our health or refers us on to someone else, that really puts us all in danger. So I can't echo enough how important this is and encourage the council to continue on with this. And like Sasha, Sean, if there is room for additional council members, I would love to be a part of this subcommittee. Also willing to come to DC and do visits on the Hill if that's something that would be helpful. I think the lived experience of what this committee or what our council is made up of is really important to telling the story. So happy to help in any way that I can. Thank you.
Thank you, Kim. I'm actually brainstorming how we do this because this is important that all council members pretty much want to be a part of. I I would love to be a part of this, but this is not my forte. This is not my expertise, and I'm probably but I'm thinking that we could probably have multiple subcommittees on different portions of it and then have one major subcommittee that takes it all. So it's a structure that goes up, and that's the way we get around the quorum situation. So we will figure that out this next week and really get that. But I appreciate all the council members' time. Mr. Solomon, thank you for your time. You're doing excellent work. Look forward to seeing more on this and as we move forward. Thank you.
Thank you, sir.
At this time, we're going to move on to our presentation on a study of denial of Florida HCBS waiver eligibility and findings. And I'm going to have Joan come up and facilitate that and then introduce our panelists.
Erica, is that you? Yeah. Okay, we got you. Awesome. Okay, so I'm Joan DeRosa. I'm NCD's General Counsel and Director of Policy, and Amy Nicholas there, she actually coordinated this panel, but I'm stepping in because she covered a lot of ground yesterday for us, giving her a little break. So I spoke about this yesterday, but when Amy was doing some research and looking for speakers for our panel on younger people institutionalized in nursing homes, she stumbled upon a particular issue happening here in Florida regarding home and community-based services. So she took the initiative of organizing this esteemed panel on this issue. As I understand it, iBudget Florida is an HCBS waiver program for people with developmental disabilities. But each year, close to 60% of people who apply are denied eligibility or closed for other reasons. And reversals of those denials are very rare. The team that you see before you and on Zoom has been systematically examining final orders on eligibility issued from March of 24 through May of 25 to identify common barriers. I'm going to let them take it from here, but I'll quickly introduce each panelist and then turn it over to them to tell us about the study. So Robert Latham on the end here is the Associate Director of the Children and Youth Law Clinic at the University of Miami, where he represents children and young adults involved in the foster care system. Dr. Cameron Riopao is the Director of Research Data and Open Scholarship and a Librarian Associate Professor at the University of Miami Libraries. Jason Kahn is a staff attorney on the Community and Healthcare Services team at Disability Rights Florida. Jason litigates Medicaid and Medicare waiver matters with the Office of Fair Hearing and the Office of Appeal Hearings. And then online, we have Dr. Erica Musser, whose research focuses on the nature and clinical presentation of neurodevelopmental disabilities with a focus on ADHD, autism, and related disabilities. So I'll turn it over to them now and start with Mr. Latham and take it from here.
There you go. Thank you so much for this invitation to present our preliminary research. We were very excited to speak to you. This project began 5 years ago, and it has involved over 30 academics and professionals in pulling it together. Lawyers and advocates began meeting about 5 years ago because we were hearing stories of increases in denials of disability eligibility around the iBudget waiver. The advocates in those meetings reported problems with the fair hearing process, with the application process, and the decision-making process. In short, the hearing officers were rejecting appeals of applicants who clearly had severe disabilities and clearly had significant needs. Advocates reporting in those meetings described having claims denied based on minor technicalities, based on testimony of the agency's own experts who had never evaluated or met the applicant. We heard from psychologists and treating clinicians who had worked with applicants for years. They could not understand why their clinical opinion of their own patient was being rejected. Professionals in the child welfare system were incredibly vocal. They would provide thousands of pages of documented evaluations and reports on a child in their system to have the applications denied based on stray remarks and other information that clinicians would never have agreed to deny someone based on. The meetings were sometimes joined by families of people with disabilities who were, quite honestly, desperately seeking services for their loved ones. Many of those families had requested the iBudget waiver services, were denied, and went on to represent themselves in fair hearings against an agency attorney and an agency expert. They all lost. We decided to form a research group to look at the issues more carefully and to look at them more systematically. We used Florida's public records laws. We were able to obtain internal agency documents and also copies of the administrative final judgments on the hearings themselves. What we found was that the issues that we were hearing in the meetings were not isolated at all. Nearly everyone who appeals a denial of the iBudget waiver and goes to hearing loses. We set out to figure out why. We wanted to do that in a fair and principled way, which is why this was a 5-year project. And I'll turn to Dr. Riopel to explain our review process a little more detail, and then we'll move on to the findings from there.
Okay, so I'll describe our research methodology quickly. We had a sample of all orders filed between March 26, 2024 and May 22nd, 2025, which resulted in a sample size of 100. We used the best practices of qualitative coding to review the documents. We paired teams of attorneys and clinicians for each document to ensure that each order was evaluated from the 2 areas of specialization which mattered most. We looked at procedural history, clinical evaluations, witnesses, and evidence, and the outcome of the process. And their goal was to evaluate the final orders to see which factors contributed to the outcome. In addition, we asked the teams to try to center the experiences of the actual people impacted by the orders. This was sometimes difficult due to redactions. We asked the teams to provide their opinions on the reasonableness of the findings as well. Whenever there was factual disagreement within the teams of paired clinicians and attorneys, we used a reconciliation process by a review committee to conduct negotiated agreement and verify the findings. When there was disagreement on matters of opinion, however, we allowed the disagreement to remain with the hope that in the future we can analyze the differences in case interpretation between clinicians and attorneys as a potential next step. Thank you.
The orders broke down about 50% exclusively autism, 22% exclusively intellectual disability, and the remainder was a mix of applicants who had applied under both categories. There were a handful, 1 to 2, that involved cerebral palsy and Down syndrome. We didn't have enough of a sample of those to say anything about decision-making process, so we set those aside for now. Our most important finding, I believe, from the review was that out of the 100 orders that we reviewed, only 2 reversed an eligibility determination by the agency. And importantly, our coders who reviewed the orders could not tell why those 2 won when so many others with very similar constellation of circumstances were denied repeatedly. To explore that issue, we organized our finding into 3 categories, which you'll hear about today. Our first set of findings concerns just issues with due process and the proceedings themselves. Our second set of findings involve the definitions that Florida's iBudget waiver program uses to determine eligibility. And then our third is a mix of the 2, and it concerns how the iBudget waiver eligibility process reviews evidence that families bring before it to make eligibility determinations. After reviewing the orders, compiling our results, we are of the opinion that the current system unfairly and arbitrarily excludes people from iBudget eligibility. There are currently over 40,000 people on the waiver. There are estimates of anywhere from 17,000 to 20,000 people on a wait list for the iBudget waiver currently in Florida. Half of the people on our wait list have been there for over a decade. We believe that there are many other people who have been disqualified or discouraged from applying unnecessarily. Mr. Khan's going to begin by talking about a summary of our findings on the due process and the fair hearing process itself. Mr. Khan.
Petitioners can be represented by attorneys in these administrative matters. However, we found that in only one of the orders, the petitioner was actually represented by an attorney. In fact, in 73 of the 100 orders, they were represented by laypersons, such as family members, relatives. In fact, 49 of those were represented by the mother. APD, on the other hand, is always represented by an attorney, and they always have their psychologists on staff. This provides an unfair advantage these are complex hearings. In order to prepare for these hearings, I need to prepare for, I depose the APD psychologist. I create evidence packets. I request evidence packets from APD. We hire experts. We have to prep all of the witnesses and all of the experts. These hearings are 2 days, sometimes 3. And after the hearing is complete, I file a proposed order, which can be time consuming because it requires listening to the audio and requesting the audio from APD. Non-lawyers don't have the knowledge to be able to go through this extensive process. In the 100 orders that we found, only 35 orders indicated the petitioners submitted their own evidence packet. And only 14 petitioners had witnesses with clinical qualifications testify. Only 3 of those witnesses were actually accepted as experts. Instead, 60% of the witnesses were lay people like parents, relatives, friends. There are obvious barriers to families bringing expert witnesses, mainly the cost. I work for Disability Rights Florida. We have a litigation budget, so whatever cases we accept, we're able to dedicate some money to hire these experts. Mainly, our main expert is usually a psychologist, a licensed Florida psychologist, and they can cost as much as $10,000, $500 an hour. And then if the hearing is 2 days in length, that's 2 8-hour days. And then it takes time to prep the psychologist. And then they need to review up to 1,000 pages of documents to be able to properly prepare. There's a significant shortage of qualified healthcare providers specifically trained to diagnose intellectual disability, and even fewer to diagnose autism because the rules to diagnose autism is more stringent. We also found that although APD has the duty to refer people for evaluations that were needed to determine eligibility, they simply flat out deny the application. Our review found that an evaluation would have been justified in 60% of the orders. Some examples would be cases where petitioners only have school records, or if they're coming from out of state or out of the country, because Florida law requires a Florida psychologist or Florida neurologist to diagnose these autism or intellectual disability. APD referred only one definitely and possibly 2 others in the orders we reviewed for a referral. Instead, they denied their eligibility. And obviously, the cost for the average Floridian to afford this expert is quite high. This would be a significant portion of their salary. And the final issue we found is that they could not get a hearing in a timely manner. Of the 100 orders that we reviewed, 322 days elapsed from the time they requested the hearing to the time the hearing officer signed the final order. And what I'm finding in my practice is that APD hearings are scheduled out until about maybe July or so of next year. So it takes a long time for them to even get these hearings.
So as Mr. Khan said, many families that come into these hearings believe that because they have a diagnosis from a clinician that worked with their loved one and they trust this doctor wholeheartedly, and this person has said that their loved one both has a developmental disability and should apply for these services, they believe that will be enough. And they cling to that and they present it to the agency staff and are denied, and they believe that can't be right. So they go before hearing officers and present it again and are denied again. What the families don't know is that the iBudget eligibility waiver standards are using definitions that make it nearly impossible sometimes to use community evaluations in this process. We're going to turn now to Dr. Musser, and I hope she can hear, to explain how these definitions arbitrarily deny people from eligibility. Dr. Musser?
Robert, I hope you all can see. One of our major findings is that the definitions that APD uses to define intellectual disability and autism are drastically and meaningfully different than those used in standard clinical practice. The iBudget definitions are outlined in the Florida statutes and regulations. In contrast, clinicians rely on definitions published in the DSM-5 TR or the ICD-11. The differences between the eligibility definitions and the clinical definitions mean that when clinicians diagnose a client, they're using different benchmarks than those required by APD. Across both diagnoses, APD's definitions are notably narrower than the definitions used in clinical practice. The definitions used by APD are also outdated and based on criteria that were published over 30 years ago. This means that the definitions used by APD to determine eligibility are not rooted in current research. This research was used to update the clinical definitions in 2013 via DSM-5 and again in 2022 via both DSM-5 TR and ICD-11. By using narrower, outdated, and non-standard definitions, APD denies eligibility to those who would otherwise qualify based on standard clinical definitions in practice. Let me give you some concrete examples. For both intellectual disability and autism, one of the major differences between the definition used by APD and the clinical definitions is the age of onset requirement. APD's definition requires evidence of onset prior to age 18 years old for intellectual disability and during infancy. Disability orders and nearly.
I'm sorry. Hold for just a second. Our ASL interpreter on the screen is, can you hear us now? Okay. No, I know. We're watching. Now he's interpreting. No, he can't hear. Nick? I'm sorry.
I hear you, Chairman, but do not hear the speaker.
You hear me, but not the speaker. I'm sorry. We're working on this technical. I apologize.
Wait until we get this resolved.
Good. Okay. Let's see. Can you speak again? I'm sorry.
Speaking.
Okay, you're good. Please continue. Yes.
Much. So we found evidence that over 10% of intellectual disability orders and nearly 30% of autism orders denied eligibility due to lack of evidence prior to age 18. Had APD relied on current clinical definitions and practices, these individuals would likely have been eligible. In terms of intellectual disability specifically, the major difference between the APD definitions and the clinical definitions is that the APD definition overly focuses on full-scale IQ scores. APD uses a hard cutoff of 70 for full-scale IQ scores. This is 2 standard deviations below the mean of 100. The clinical definitions recognize that this is an arbitrary cut point and recognize that all IQ tests have measurement error inherent to the test, even when administered in a standardized way. The clinical definitions account for this by allowing scores approximately 2 standard deviations below the mean with reasonable clinical judgment. So for example, we repeatedly saw in the orders that APD and hearing officers would deny someone with a full-scale IQ of 71. The clinical definitions recognize that a score of 71 is not meaningfully different than a score of 69. APD rejected potentially qualifying IQ scores according to the clinical definition in roughly 45% of intellectual disability orders. The APD's over-reliance on IQ scores also discounts a large body of empirical evidence that shows that adaptive functioning is a stronger predictor of ability to live independently than full-scale IQ. The clinical definitions equally weigh IQ and adaptive functioning in diagnostic decision-making. So again, someone with a full-scale IQ score of 71, but significant impairments in adaptive functioning, for example, an inability to work, an inability to wake up using an alarm, poor self-care, would clinically be found to have a developmental disability and need for significant support, possibly to avoid institutionalization. Under the APD standards, they would be denied. For autism, APD appears to be relying on the DSM-4 definition, which was published in 1994. The definition used by APD uses outdated symptoms and criteria compared to the current clinical definition. So, for example, APD's definition requires evidence that autism is neurologically based. I personally don't know how a clinician would determine this. There are currently no biological tests that I am aware of that are sensitive to or specific to all autism cases. The APD definition also places a larger emphasis on the number of symptoms present rather than the quality of those symptoms. For example, in the APD definition, a lack of imagination is given equal weight to complete lack of spoken language. Clinically, it's known that lack of spoken language would cause more impairment and so would be given more weight. The eligibility definitions ignore scientific evidence that suggests that the number of symptoms present does not map onto level of impairment, which should be used to determine eligibility. Finally, the APD definition for autism requires that the disability cause severe learning, communication, and behavior disorders. To be quite honest, as a clinician who's been working in this field for over 15 years, I don't understand what this means. This isn't part of the clinical definition, and to my knowledge, there's no empirical evidence that autism causes any other disorder. Autism is associated with impairment in learning, communication, and behavior, but it does not cause other disorders. Importantly, these differences in definition also mean that clinicians writing the reports to be used for clinical purposes do not know that they need to speak to a different set of criteria than those used in standard clinical practice. Clinicians in practice are trying to give a reasonable clinical picture, including client strengths and weaknesses, as well as treatment recommendations. They're not trying to document the forensic levels needed to withstand the scrutiny of a court of law. We repeatedly saw applicants penalized for things evaluators did or did not document explicitly in their reports. This makes the lack of referrals for external evaluations described by Mr. Khan even more egregious. This is also a finding that would be easily addressable by APD in the Florida legislature. They could simply update their definitions to those using current scientific literature and based in current standard clinical practice. So overall, APD's definition is more narrow and outdated than the clinical definitions, which are based on decades of empirical evidence, and this results in the unfair exclusion of those who require the services provided by the waiver. The next major finding concerns APD's interpretation of clinical evidence, which typically uses clinical reports, medical documentation, educational documentation, and the like. By misinterpreting clinical evidence or misrepresenting clinical evidence, APD is unfairly denying individuals who may otherwise be eligible. Here we found that APD often inappropriately interpreted evidence to deem the applicant ineligible due to having an uncertain prognosis or a lack of pervasiveness of symptoms. For example, APD used improvements in eye contact in the context of therapy to demonstrate that one applicant's prognosis was uncertain given those improvements. Similarly, a change in diet was used as evidence that the applicant's repetitive behavior symptoms were not likely to continue indefinitely. This evidence cited a report provided by the applicant, and the final order says, and I quote, "The family reported a decrease in repetitive behaviors such as shaking his head when excited, roaming the house, and walking in circles following a dietary change." To my knowledge, there is no empirical evidence that suggests that a dietary change can cure autism symptoms. These are just two examples of the type of misrepresentation of evidence that I'm talking about. There were many, many more. Clinically, these instances of improvement in a single area would not be used to make claims about long-term prognosis or ability to live independently. Such a misrepresentation resulted in the unfair denial of many applicants. Another example of APD inappropriately interpreting evidence is related to their focus on irrelevant or stray comments provided in clinical reports, school records, and other non-clinical reports. For example, APE used a clinical report documenting an instance of eye contact during an evaluation as evidence against an autism diagnosis. APD also used attention during an IQ test to claim that the test was not a valid representation of the individual's ability, even when the clinician who administered the test and wrote the report did not indicate this. Again, clinically, such evidence may not impact a diagnosis. It would depend on what other information was available. APD expert witnesses also often make comments that were not backed by scientific evidence. For example, one APD expert testified and a hearing officer found that individuals with intellectual disability do not show patterns of strengths and weaknesses. I want to say this is categorically false. Another APD expert witness testified and a hearing officer found that individuals with autism do not display facial affect or understand humor. This is also false. There's huge heterogeneity among the population of individuals with autism. Some show facial affect, many understand humor. Neither of these statements are backed by scientific evidence or clinical practice guidelines, and they show a fundamental misunderstanding of the experiences of people with disabilities. Additionally, other diagnoses like ADHD or bipolar disorder were often used in the orders to deny eligibility, with expert witnesses claiming that it was not possible to determine whether it was the neurodevelopmental disability or the psychiatric diagnosis that resulted in the impairment. Clinically, it would not matter which diagnosis was causing the impairment. Intervention or support services would still be needed to allow the client to live independently. There were additional examples of inappropriate interpretations of evidence that were specific to intellectual disability. Full-scale IQ is only one component of the overall pattern of IQ scores. IQ tests are made up of several subscores in addition to the overall full-scale IQ. For example, this might involve verbal intelligence, processing speed, or working memory. APD required that there be no pattern or strengths of weaknesses among these scores and that scores not significantly vary from one another. This is not in line with current scientific evidence or clinical best practices, which expect variation in subscores, even among those with intellectual disability. Additionally, such patterns of strengths and weaknesses are not necessarily predictive of a person's ability to live independently, which would be better predicted by their adaptive functioning. In cases with multiple IQ scores, either those from different tests or taken at different times across the applicant's lifespan, APD did not consider measurement error or misused confidence intervals to deny eligibility. So for example, APD would deny someone with scores of 72, 68, and 65. Again, clinically and statistically, those scores do not differ from one another. The 95% confidence interval of these scores would be roughly 64 to 76, meaning the individual scores in that range do not meaningfully differ from one another. By misinterpreting the evidence in this way, individuals are being unfairly denied. Overall, our analysis shows that the eligibility determination process is unfairly denying applicants due to outdated, non-empirically supported definitions, and inappropriate interpretation of evidence that is not rooted in clinical best practice or the current empirical literature base. And now I'm going to turn it back over to Mr. Latham. Thank you.
Members of the council, we want to end with just a few individual thoughts before we open up for questions. This team came together to study this problem because we care about it deeply. I've handled cases for years for children and young adults in foster care, and they're both in foster care and their families' homes, were repeatedly denied support that could quite literally have saved their lives. This process needs to change so that people have a fair chance to access these supports and services. Mr. Khan.
So I've been a practicing attorney for about 10 years. And to work on these cases, I use all of my knowledge and research, and as well as Disability Rights Florida's litigation budget, which we're the protection and advocacy agency in the state of Florida. So we get federal funding. And so the cases we take, we're able to spend money on them. And despite this, a favorable result is not always guaranteed. And so it's quite obvious that most of the petitioners here in Florida don't have the financial means nor the legal knowledge to be able to have a fighting chance.
Dr. Riffle?
And I'm a sociologist and statistician, so my perspective echoes in a way what I just heard, which is that people are paying for a process that isn't working. And for many of these people, the amount is either too much to pay, so they may not even appeal, or they are devoting a large proportion of their income, sometimes $5,000 to $10,000, to obtain evidence that may not be taken seriously and maybe no guarantee of fair evaluation. And all this is happening at a time when obtaining clinical, psychological, and legal services is harder than ever. And it's using time of those experts as well. Thank you.
Dr. Musser.
As a psychologist, it's really disheartening to see my clinical opinion and that of other professionals like me either discounted or expected to meet standards that don't match those that are set in current clinical best practices. It's also disheartening to see my words and the use of words of other professionals like me taken out of context and used against me, especially when strengths-based evaluation is used to deny eligibility. I always speak to the client's strengths when I do an evaluation in their clinical report. And oftentimes it's those strengths specifically that APD focuses on in their evidence in denying eligibility. Thank you.
Thank the council for its time. We're open for questions.
Questions from the council? Anyone? I have a question. I just don't know how to formulate it right off the top of my head, but because it's very disheartening to hear. So you guys are just studying Florida. So my assumption is this is happening in other states. And if you weren't here, California, we're a little bit spoiled on this side. It's a little bit easier to get services. The comment, I mean, listening to some of the testimony is about the diagnosis is we're back in the days of refrigerator mother. And it's all caused by the parents. And so, I mean, where at the federal level would you guys suggest or have suggestions for us to recommend at the federal level for this?
So I believe the council is well positioned for one, to document the issues. So Florida's iBudget waiver application states that it works with people with developmental disabilities, including autism and intellectual disability, but then goes on at state law to define it in ways that exclude people outside the standard definitions. That is the easiest. Your description of differences among the states is very important because it's not documented clearly here, but there are a subset of cases where families from other states who are receiving the waiver, a federal program, move to Florida thinking they are going to have access to the same level of services because there's a same waiver here, only to get denied once they've moved, and to go through fair hearing processes and try to fight the denial only to learn, oh, I'm sorry, Florida's standards are different. So we understand the importance of flexibility in the federal waiver process, but also portability has to be more of a conversation for families. Florida has a very narrow exception for military families that move so that their eligibility is supposed to continue over. And even military families experience this, where they get stationed here and lose access to their services that they would have had somewhere else. That's the first piece. We are strongly recommending, of course, that NCD hear from the families affected. We're professionals, but there are many families who have been through the fair hearing process and felt like they were on trial for asking for help. They were cross-examined by agency attorneys. They were told by agency psychologists that what they were observing in their loved one just couldn't be real or was not severe enough. And to your point, that harkens back to a time that I don't think we should be in anymore, right? I defer to the other council or the panel members if they have additional recommendations.
This is more Dr. Musser's domain, but I do believe that this state's reliance on the DSM-4 might be echoed in other states as well. We've limited our research to Florida, but that'll be something to have as part of this ongoing project.
Just for the record, would you tell us, this is the Diagnostic and Statistical Manual that you're speaking of, right? DSM?
Yes, Dr. Musser.
Correct. The DSM stands for Diagnostic and Statistical Manual of Mental Disorders. So that is the document, the book that we are describing here. As I mentioned, relying on DSM-4 is really unacceptable because that document first came out in 1994. So it is over 30 years old. But what that means, because the process of coming together and putting together the DSM takes years, it means that the research that supported those initial diagnostic criteria for the DSM are well over 30 years old at this point. And the research on autism and intellectual disability and what those disorders are has come a very long way in the last 3 decades. We're currently on DSM-5 TR, and that was updated in 2022. So there's really not a big excuse for not updating these definitions.
And isn't the DSM-6 about to come out this year? Like the updated manual? So it might be that we can make a recommendation that, given a new DSM is coming out, this is the time to update the standards. But
So have you presented these findings to the state and asked them to update it? What's your experience there?
So we're a wide coalition. Different parts of our coalition have different interactions with the state. I work in both the policy and the litigation space, so I've asked them to update their standards in every single case I've brought, and of course been told no. DRF meets regularly with the state agencies. That's part of their role. There is currently a bill pending in Florida to update the autism standard, but I do believe it's been filed multiple years in a row and has not yet received a hearing.
So it's been years since I've looked at the DSM, and I'm assuming the DSM-4 had autism had a very unique category, and then the DSM-5 represents more of the spectrum, correct?
Dr. Musser.
That's absolutely correct. So DSM-4 and DSM-4-TR still had separate categories for Asperger's syndrome, autism spectrum disorder, pervasive developmental disorder not otherwise specified, and DSM-5, which again came out in 2013, represented a dramatic shift there, such that all of those diagnoses were collapsed into a single diagnosis, which is autism spectrum disorder. So yes, it's a pretty dramatic difference for that diagnosis specifically.
Thank you. And then just final, my assumption, dealing with some issues in California a few years back in the HCBS system and waivers, is individuals are not allowed to sue the state to follow even their own plan for HCBS or to update it. It has to come through the federal government because of standing, correct?
Yes, I've dealt with some cases where APD erroneously didn't qualify an applicant due to some wrong reason, and then we try to get reimbursed for that money, and they do have sovereign immunity, so There's
So
no
unless
way
they
around
tell
that.
you that you can sue us and go further, once the appeal process is done, it's done.
Yes, correct.
Thank you.
Mr. Chairman, I, I'm always interested in the what. I guess what eludes me sometimes is the why. You know, why is this? Why is it 30 years since they've changed it? Why? It almost seems adversarial. And you must have a theory, even something you may not want to state, and if you don't want to, don't. Why it is so difficult. Is it truly a lack of belief on the one side? Is it a desire to save money? Why?
I don't want to speculate in a public setting why. I think those are valid questions directed to the state. We should clarify. Let me say something for background really quickly. In the same time period, 30% of the people who applied for APD services were approved. About half of that 30% may have found their way to the waiver and actual services. The rest were put on the wait list that we described. So there are people being approved. We don't have access to the applications that didn't become public through the fair hearing process. What we see in the fair hearing process, though, is the public advocacy by this agency against families uses standards and definitions that just seem so incredibly out of touch. And it's not for lack of education or having any other advocate on the other side in limited cases telling them that they're wrong. So the why eludes me. It's not from lack of education. Dr. Gable?
I just want to add that from a statistical perspective, it's quite arbitrary, this 70 confidence interval for the full scale IQ, where if somebody has a 71, it's denied. If somebody has a 69, well, it's probably a 70 or over because it's a confidence interval. So it's basically the confidence interval based logic does occur sometimes when it's near 70 from below. But then when it's 70 or above, if 71, it's clearly not below 70, even though interval could be either score from a statistical perspective. And I think the misuse of statistics at people is worth looking into.
Right. I will say, again, not to try to say why, but to explain what this process does, it effectively says that Florida does not have a problem helping people with developmental disabilities because the people who have applied don't have developmental disabilities. As opposed to they have developmental disabilities, they need support, but we can't meet their needs. So this process has declared some people just ineligible by default and by definition, when that is absolutely not true.
I'm just flabbergasted that it takes so long for an appeal. Even California is 30 days. You have to have an administrative hearing within 30 days of a denial, if requested. So, and it's an administrative judge, and it's usually a local person for the centers that are doing it. But any other questions? Oh,
Great study.
yeah, I really appreciate your time. And that's, we're looking forward to that. John, anything else?
No,
Thank you so
that's
much.
it. Thank you so much for coming.
Thank you very much.
Thank you. Okay. I'll take it. Yeah, I'll take it. I'll open the book. So at this time, being the acting chair of the National Council, it's my pleasure to present the following. Just a little bit of background. We came to Orlando because our council member, Neil Romano, sitting here, who I adore and am proud to look up to him and his accomplishments. Has been on the council for 10 years. And he served as the chair back. But I'm going to give you a little history because I had a pleasure of running some history, and this is part of his history that I didn't even know until I did this research. So as far as back as I can go, Mr. Romano in 1984 ran for Congress out of New Jersey. While he was not successful, he was then appointed to the Director of Communications for the White House, Office of Drug Abuse Policy. Under that, he was instrumental in the Just Say No policy. You can stop me if I'm wrong on any of this. And the America Response to AIDS policy under the Reagan administration, and was a right-hand person for Nancy Reagan. He was nominated in 2007 by George W. Bush and unanimously confirmed to be the head of the U.S. Department of Labor Office of Disabilities Employment Policy, ODEP. In 2010, this man was nominated for an Emmy for his film for Best Director on his film Youth Homicide: A Public Health Crisis. And that's just before he ever came to the National Council. So in 2015, Senator Mitch McConnell appointed Mr. Romano to the National Council on Disability. I'm sorry. Yeah, in 2015, correct? In 2018, President Trump appointed him as the chair of the National Council. He's continued from 2015 to play a massive role in helping this mission and shaping the policies that we present to Congress and to the White House. Since this is his hometown, his beautiful Florida hometown, or where he now calls home, we wanted to take this opportunity to recognize him here in Orlando and to thank him for his 10 years of service to this council and to the United States. At this time, we have an award for him that I'm going to read what it says. As a token of our appreciation. Let's go the right way. It says, in gratitude to Neil Romano for 10 years of devoted public service devoted to the National Council on Disabilities 2026. So Neil, at this time, we want to thank you for this. I'm going to present this to you.
Photo op. Yes.
So one other thing I wanted to point out, just last week, I asked Neil to be the vice chair for the National Council, and he accepted. So he is now the acting vice chair for this National Council. And then right now, I wanted to open it up to the staff of the National Council who have worked with Neil for their remarks, if they have anything.
Theo's.
And Theo. Oh, sorry. We'll wait for Theo to please. Please, Theo.
Oh, can you hear me?
We got you.
All right, I couldn't let this moment this go by. Neil's my guy, right? Neil is, he don't put out his accomplishments out there. You don't wear him on his sleeves. He just have quietly done this stuff for so long. And I just wanted to say to you, Neil, how much I appreciate you, how much I look to you for advice and counsel, right? It's not too many people that can change my thoughts on certain topics. I'm like a rock rider when I have a particular feel for something or thoughts for something, but I have learned over the time working with Neil to listen to him, and he have, to my surprise, changed my position on stuff. Not too many people can do that. And so, Neil, I just want to let you know that you are someone I highly respect and look towards. And I just appreciate who you are. And so please don't ever change. So congratulations.
Thank you. Sasha.
Yeah, I just wanted to say that I really enjoyed working with you.
I just wanted to say that I've really enjoyed working with you.
That especially appreciate
And I especially appreciate
how you focus on advocacy within the medical community.
and appreciate your focus on advocacy within the medical community.
As viewed as such a critical issue.
And as we just mentioned, it's such a critical issue.
And my really love that you laser focused on it.
And I really appreciate that you're laser focused on it.
Then thank you for everything you do.
And thank you for everything you do.
Joan.
So Neil, we have other people on.
You guys trying to figure out who's going to make me cry today, or is this like a collective make Neil cry?
There's a pool.
Thank you.
I'll try. I've probably been working with you the longest of the NCD staff and council in the room. And of course, you're amazing to work with. But I wanted to tell everybody just one thing. My husband, my late husband, passed away from cancer almost 7 years ago. And it was in July of that year. And it was right before a council meeting when Neil was the chair. And, the current executive director, of course I couldn't go to that meeting because of that. I had to, make funeral arrangements and do that stuff. And so I couldn't be at the meeting. And the current executive director at that time let me know that during the meeting, and I never expected this, that Neil had called for a moment of silence during the public part of the meeting for my husband. And that was just so moving to me that he did that. He had not met my husband, Carlos, but despite that, he wanted to show that support for me and what I was going through. And I've always really appreciated that. And I don't know, I was glad I have an opportunity publicly to kind of thank you for doing that. It was very moving. So thank you, Neil.
Any other comments? Yeah, Jed, please.
So Neil and I had an opportunity to take a road trip to the University of Pennsylvania together. It's kind of a business trip, but it was also kind of like a fun buddy trip too. And I wish everybody else on the council and staff could have seen what Neil did that day. The venue was, of course, filled to capacity. And everybody was just so interested in hearing what our then chairman had to say about NCD's successes. And that's the thing. Neil always supported NCD in going after the difficult to achieve successes. And Neil's a baseball guy, so I'll just put it this way. Neil, you swing at the tough pitches and you knock it out of the park. And it's a pleasure to work with you.
Thank you so much. Thank you so much. Thank you. Thank you.
I apologize. Kimmy.
Okay, now I know how to turn on the mic. Well, even though I'm the newest staff member at NCD, I've known Neil since 2016, 2017, when I first came to the DC area from the National Federation of the Blind, when we were working on Section 14C issues. And ever since then, I've gotten to know Neil professionally, as a person, as a friend, and I do consider him a mentor. He's someone I can pick up the phone and ask, like, what does this mean? Or how do I say this more politically correct? And he's always has good advice. And so one of the things I admire about Neil is that he never retires. He's always doing something else. He's like an Energizer bunny. So I hope eventually I can do that too, be like as old as Neil and still working and still have my brain together, like Neil does. So congratulations on your award. And, I look forward to being old and like you and energized like you.
She just called you old.
That was a compliment. That was a compliment.
Thank you, Kimmy. But let me please say that getting old is certainly better than the alternative. which I have faced, so.
So I just want to make clear that everybody listening to this, Neil's not going anywhere. This is for his 10 years of service with us. So he's not allowed to go anywhere.
Hey, Neil, I've been around, I think, with you since you started in 2015 with NCD and have many fond memories, one of them being our trip in New Hampshire and Vermont and eating at the dive restaurant. Do you remember that, where it was like off the beaten path and but just had an enjoyable time with you, spending time and getting to know you and your drive and your passion for NCD and to constantly strive for improving the lives of people with disabilities. It was especially grateful that you allowed me to go to the Nat Stadium to join that day with the trainers and when we had the players there. So that was a lot of fun as well. So I look forward to working with you in the future as well. We've had a lot of
Thank you so much.
a lot of accomplishments made. So looking forward to more moving forward.
Thank you. Thank you very much. Thank you.
Excellent. Anna.
You know, I have to say something, Neil. I came onto the council about 6 months after you did. Working under Joan DeRocher in the policy team, legal team. And for the first couple years, you know, I observed you on the council and understood, you know, that how important you were to us, the decisions that you made, the contributions that you made. A few years later, we started working together much more when you became the chairman. And we wrote a lot of letters and a lot of things together. We worked very closely together. And in that time period, you know, I learned a lot about what you believed in and what you stood for. And and you taught me a lot of things. And a lot about like what Kimmy said about how to be you know, more tempered in presentation. And but one of the things that I just want to say is thank you for the time that you spent with me and that you still do, and all of the things that you've stood for over the years and how you've stood strong. And when you make decisions, you stick with those decisions. Just thank you for the time with you and me. And I hope that we have many more years working together. And just thank you.
Excellent. We good?
Sean, can I say something?
Yes, absolutely. Yes,
Thank,
absolutely.
thank you. So Neil, as the newest member of the council, I just want to say thank you. I have thoroughly enjoyed all the conversations that we've been able to have. I've already learned a tremendous amount from you. I am exceptionally grateful that this is not an award because you have decided to leave the council. That I was a little worried, I will admit, for a few minutes. So Sean, thank you for clarifying. I just want to say I am in awe of how you present yourself, how you present the issues that you're talking about and your career in general. It's something that I think most of us in every room we go into feel the same way. So congratulations. And I'm so grateful to be able to continue working with you.
Thank you. Thank you very much. Thank you, Kim.
Excellent. Neil, would you like to say anything?
Well, you know, Mr. Chairman, first of all, thank you. But for you to ask me if I want to say something, it's kind of, you know, come on. If Neil has nothing to say, something's wrong. I want to first say that if anyone sees anything good in me, it's my faith. It's my Lord who has given me the strength to understand what my, whatever it is, ability to help other people is. I'd like to just say that you have so many people that said nice things about me, but I've been informed by every single one of them. And by the way, no one's ever seen Theo and I in the same room, so people are starting to wonder if we are indeed the same person. But I love you, Theo. But I have been informed by the staff at NCD, Anna. I mean, you talk about, we sit up here, guys. Let me be honest with you. We sit up here and we do this, but it's all these folks who tell us how to do this. They write the reports. They do the work. Yes, we may come up with the ideas, and I have been blessed to be able to work with these folks, and it has been more than a pleasure. One quick thing. When I was first asked to be on the council, I was laying in a bed in MD Anderson where I was a resident, and I had leukemia, and they said I didn't have much time. So when I was called and asked, they said to me, we'd like to know if you'd like to be on it. And I said, well, how long is the appointment? They said, this was 10 years ago. I said, 3 years. I said, well, I don't know if I'm going to give you 3 years, but I'll give you as much as I can. And by the grace of God, I've had the opportunity to do this.
Amen.
And I want people to understand this is an incredible honor today because of how I respect every single person in this room. That doesn't necessarily mean we always got along. Doesn't necessarily mean every decision was agreed upon. But by the grace of God, we've had a single goal, and NCD has had a single goal. And I have been so proud to be part of that, to be able to push forward every day. We don't come here to ever talk about anything but the rights and the needs of people with disabilities. And I'd also be remiss if I didn't say that I've worked with a lot of council members over the years, and I have yet to sit here and ever see a council member or person who was ever doing anything for self-serving purposes, anything that they did except for people with disabilities. And I have to tell you, it is a great pride in my life to work with these folks. And I would like to thank you, Mr. Chairman. When you called a couple of weeks ago to say you wanted to talk to me, I thought you were going to say, hey, Neil, you're fired, which was really, so when you asked me if I would be the vice chairman again, be the vice chairman for the first time, I am greatly honored. And for as long as, I'm allowed or I can, I will be working for NCD on behalf of people with disabilities. And I appreciate it. Thank you all, and God bless you all.
Thank you so much. That brings us to the end of, as we're all sitting here, I'm sitting here in tears.
Thank you.
I just can't tell you how much I appreciate the conversations you and I have had on issues that we have disagreed on. But people often ask me about the council, and well, you guys come from political different backgrounds a lot of times, and it's like, no, we don't. I believe even our political affiliations this is how Congress should work, where we discuss things and figure out resolutions and play, but we all are here for one thing, and that's the disability community, and how do we support that? And I really appreciate everything for you, my friend. With that, I'm going to ask for a movement to adjourn this meeting. Sasha first. Do I have a second? Second. Hosky seconds. And all in favor. And if anybody says no, we're going to have words. So, aye.
All right.
We are adjourned. Thank you.
Bye-bye, everybody.
Bye, Theo.